Still just loading. Okay, and we are live. Hi, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Sheneen Lalani. Our session today will be on palliative care and hospice. As always, please remember that the Google form will be posted in the chat box at the very end of the session. For those who were here yesterday, I mentioned that we're no longer going to be posting it in the Instagram bio, so just go to the YouTube chat box for that form. With that being said, Dr. Laulani, you can get started whenever you're ready.
Hello guys, hello web shadowers. I am so excited to present today. This is a topic that's very close to my heart. We are going to be talking about the field of palliative care and hospice. I will give you a quick overview of what it is. We'll go through a case together, like it's an actual shadowing session, like you're with me in the hospital. We'll go through the case. We'll talk about things I would be thinking of as a doctor when approaching this patient, different topics related to the field. And I also want to talk about general understanding of, what happens when a patient dies, what exams we do to make sure they are dead, things we think about, and most importantly, also how to deal with a patient's death. If you are in the field of medicine, whether you are a doctor or nurse or a nurse practitioner or PA, whatever field of medicine you are in, at one point in your career, you will be dealing with someone with a severe chronic illness, whether it is cancer or end-stage heart disease or end-stage lung disease, and you will see a patient die. It is a very, I feel like, hush-hush topic, and not a lot of people talk about it openly, but I think it's such an important topic to address and talk about because it's something all of us as doctors, all of us as medical providers will experience one point in our life, and it's important to kind of learn how to deal with it. And it's also important to learn how to deal with patients that have chronic serious illness, like end-stage dementia or cancer or heart disease or lung disease, and the approach to take care of these type of patients. I know most of you will go into different fields of medicine, whether it is cardiology or pulmonary or dermatology, but obviously there are certain fields that don't deal with a lot of chronic type patients, but as a medical student, when you will be doing your rotations, you will be seeing patients that are very sick. And it's important to attach a humanity to them and learn how to deal with it. Palliative care and hospice has also been, there's been a huge push to have introduction to this field incorporated into medical schools. I did my training at NYU for my fellowship, and I know NYU School of Medicine has a huge palliative care and hospice curriculum incorporated in medical schools to teach students how to approach certain conversations with patients, how to approach patients that have serious illness. So we'll also touch on that so you guys can get like a general basic understanding. I know a lot of you probably won't, I don't know if you guys would consider palliative care and hospice as a specialty, but even if you don't, this is a very important field to familiarize yourself with because it's something all of you will see one point in your life. So a little bit about me. I grew up in Dallas, Texas. I went to UT Austin for undergrad. I did my major in psychology, along with economics and biology. And I moved to New York City for medical school. I went to Touro College, and I did my internal medicine residency in Brooklyn, New York. And I did my fellowship at NYU in the city for palliative care and hospice. So the training is, 4 years medical school, 3 years of internal medicine residency, and the fellowship itself is 1 year. I work as an internal medicine hospitalist, which means when patients are admitted into the hospital, I manage them. So let's say if someone comes to the ER with chest pain, the ER doctor says, okay, this patient needs to be admitted because he's having a heart attack. I'm the person this patient is admitted with. So I'm the hospitalist that manages patients that are critical enough to be admitted into the hospital, and I coordinate care with other doctors. So for example, when someone comes in with chest pain and they're having a heart attack, I'm the doctor that will be coordinating the care with the cardiologist, which is the heart doctor, to see what we can do for the patient, what procedure the patient needs. So the hospitals are kind of a point of contact for everyone. So I do that about 2 weeks out of the month. The rest of the 2 weeks, I work as a palliative care and hospice doctor, which we'll go over what this field is. I am also a locum doctor. A locum doctor is a doctor that goes to places where there's a severe shortage of doctors. So I go to a lot of hospitals in rural America that has a severe shortage of doctors. So I do that 1 week out of the month. So I'm an independent contractor. So for example, I go to like rural areas of Missouri or rural areas of upstate New York or rural areas of, Nebraska, where hospitals are very understaffed because not a lot of physicians can, travel to these really far away areas. So I go there, I work with companies that fly me there. They put me in a hotel there for a week, and I see patients at that hospital as a hospitalist. So, I help the ER doctor admit these patients into the hospital and coordinate care. So I love doing that because I like traveling. It introduces me to different people from all over America. And I also like giving back because I feel like there are a lot of places in America that have a shortage of doctors, and our own country has areas where, there's not a lot of medical help available. So that's a little bit about me. That's what I do. I do a little bit of everything. And I also practice as a concierge medicine doctor in the city in Manhattan. A couple of days out of the month, I go to this private clinic in New York. It's at Rockefeller Center, and we see certain type of patients that have affiliations with certain companies. So the point of all this is that when you're doing your medicine training, I feel like not a lot of people know that there's so much you can do. You don't just have to do one thing. And I think that's really important to understand. And I wish someone told me that earlier. I enjoy being a traveling doctor. I enjoy being an internal medicine hospitalist. I also enjoy being a palliative care and hospice doctor. I enjoy being a locum doctor, and I enjoy being a concierge medicine doctor. So there's so much you can do. And so when you're done with your training, there are traditional fields where most people end up just doing one thing and practicing one field. There's so many fields that you can practice together and make your own schedule. Throughout, since I am from New York City, and I've lived here for 10 years, throughout the pandemic, I have been working at a pop-up hospital that just closed. So pop-up hospitals are hospitals that have been erected because, our hospitals were getting clogged with so many patients, and we didn't have enough resources in hospitals. So the government opened up these pop-up facilities where locum doctors like me were staffing it. And so a lot of severe COVID patients would come to our tents that were erected where we would be treating them. So that's been very rewarding, just being front lines in New York City. The pop-up hospitals just closed about a month ago here, all of them. And so now I'm back at working at hospitals. But it was a very crazy experience working at these pop-up hospitals with military doctors being front lines because it was such a great learning experience for me. So with further ado, let's go on to our topic. Okay, so this is a common case that you see that we are usually, as a palliative care and hospice doctor, consulted for. So this case might be a little heavy for some people. So if you feel like you need to excuse yourself, it's okay. But this is a common case that we see. So Mrs. Smith is a 45-year-old female with stage 4 metastatic breast cancer. She's admitted to the hospital with severe pain in hip and lower extremities and upper extremities due to bone metastasis. Her disease has progressed and she is more tired, with decreased ambulation. She follows with the oncology clinic regularly, and currently she is not a candidate for chemotherapy due to progression of her disease. You are consulted for pain management and goals of care. A little bit of background on her. She is married with 3 children. She used to work as a biology teacher in high school, and she's very involved in her church and community. Now, this is an actual case that I've seen, but I usually see cases like these. So it's usually metastatic disease or end stage dementia, end stage congestive heart failure, end stage lung disease. And patients come in with severe symptoms. And my job as a palliative care and hospice doctor is to manage their symptoms and have goals of care conversations. Goals of care conversations are conversations that we have with patients to kind of initiate conversations regarding end of life care or just the type of care they would like to receive. So a lot of my job also includes breaking bad news to patients about, now the oncologist has said that we are no longer offering chemotherapy. What is it that your goals, what is it that you want to focus on now on? And we'll go over all that. But this is usually a case that we see. Now, I want to kind of walk you through what my thought process would be when I see this patient, and details and pathophysiology of the disease and her pain, and what is it that I would be targeting with my team. So just an overview, this patient has metastatic breast cancer. She's no longer a candidate for chemotherapy. She's coming in with severe pain in her extremities and multiple sites because of bone metastasis, and you're called to manage her pain. So palliative care is a field in medicine that focuses on anyone with a chronic serious illness, whether it is heart disease, end-stage kidney disease, patients that are on dialysis for a long time and no longer want to be on dialysis, end-stage heart disease, end-stage lung disease, whether it is COPD or interstitial lung disease, cancer, neurological diseases like ALS, any chronic disease. This is where palliative care doctor comes in that coordinates care with the primary doctor. The goal of palliative care is to provide relief of symptoms and stress, along with providing support to patient and patients' families. We're always working in a interdisciplinary team. So when we are consulted for a patient, it's not just me that sees the patient. I have a team of nurses, nurse practitioners, palliative care chaplains, because spirituality and spiritual health is also very important when you're seeing a patient, along with social workers that help coordinate the care. We can be consulted at any stage of the illness. So let's say someone is diagnosed with cancer and they're having cancer pain. That's when we would be coming in, helping the oncologist manage the patient's pain. And it could be provided along with curative treatment. So if someone has cancer and they're having cancer pain, we can still come in even if patient is getting chemotherapy. A lot of people think palliative care is for patients that are end of life, but that's actually not true. It's for patients that have chronic illness. Hospice, on the other hand, is for patients that are end of life. So palliative care and hospice, the way I always describe it, is 2 different fields under the same umbrella. So palliative care is for anyone with a chronic illness. Hospice is for patients that have a life expectancy of 6 months or less. So in order for anyone to be eligible for hospice, they have to have a life expectancy of 6 months or less. People often think of hospice as this place patients go to, but it's actually a service that is provided, and it can be provided anywhere. It could be provided in patient's home, which is the ideal place. Ideally, we would love to provide home hospice for patients, which is where patients die in the comfort of their own home, surrounded by their family and friends, which is an ideal way to die for most people. But it can also be provided in nursing homes. There are a lot of elderly patients that have been living in nursing homes for a very long time, and this is their new home. And at the same time, it could also be provided in inpatient hospital settings. So let's say if someone is admitted and they are actively dying and they have nowhere to go, then we could provide these hospice services inpatient. So the hospice services, for example, let's say if someone has decided to opt for home hospice. So they've decided that they want to die at home. They don't want to continue coming to the emergency room and be admitted to the hospital. So when this patient is at home, they opt for hospice, home hospice, which is covered by Medicare and Medicaid. And what happens is that the doctors actually visit patients at home. So I make house calls to patients that are on hospice. I visit them about once a week or 2 times a week or whenever it is that they need me. But along with that, there's nursing staff that goes and visits patients at their home a couple of times a week. There's social workers that visit patients at home. There's chaplain that visit patients at home. And mostly patient is taken care at home by either their family members with additional help provided by home health aides. But the goal is for them to just be comfortable at home. So like I said, it's an interdisciplinary team approach. My team consists of me as the doctor. I have a nurse, especially in the home hospice setting. Nurses are definitely front lines and definitely going to see the patient a couple of times a week. And so they're very involved in patients' care. We also have a nurse practitioner on our team. We have a social worker because patients' social needs are very high, especially with anyone that has a chronic illness or end of life. And then we have chaplains. Chaplains are a huge part of our team. When we treat the patients with a chronic illness or the ones that are end of life, spirituality is a big part of who they are. Like with this patient in this case that we will be discussing, she is very involved in her church. And so when we look at the patient, we have to see the picture as a whole, her family, her children, what is it that's important to them? Just, her personhood that makes her who she is. And a lot of patients have spiritual distress, especially end of life. Doesn't matter what their religion is. The chaplain usually is someone that goes to the patient's home or speaks to patients about, how they're feeling spiritually. And sometimes people can have, spirituality related pain and distress. If they're really religious, they might be thinking that why is it that I have cancer? Is God punishing me or what's going on? So there's a lot of factors and domains that go into patients' care besides just the medical part. So that's why we always work in a interdisciplinary team. There's also grief counselor and therapists, especially, for example, in this patient, she has 3 children. So, it's not just me as a physician that will be explaining the care. There's also grief counselors and therapists that might be needed sometimes to talk to these children. So that's one of the things I love about palliative care. When you see these patients, you are not just taking care of, the pain or the difficulty breathing or this symptom. You're taking care of the patient as a whole, which definitely adds like the humanity aspect of medicine to it. So like I talked about earlier, the approach to palliative care and hospice is the whole mind, body, and soul approach. We believe that everything is related. If you are having distress in one aspect of your life, it can actually impact your pain. If you're very stressed and if you're not getting proper psychosocial help, then that could also be impacting your pain and distress. So as a physician, a lot of my job is pain and symptom management at the medical level. But working in a team, we address, psychosocial issues, religious issues, and look at patients as a whole. So let's go back to the case. The 45-year-old female with metastatic breast cancer came in with hip pain, lower extremity pain because of bone metastasis. Oncology has told us as the team that they're no longer going to be offering chemotherapy. And then she has 3 children. She was a biology teacher. So now I kind of want to walk through what goes on in my head. So that when I first see this patient, there are a few things that I'm thinking of. The first thing I'm thinking of is that my main priority as the doctor is to manage this patient's pain. So we'll go through what will be going in my head when it comes to pain management. Besides the pain management, the other thought process is that I have to tell this patient with the oncologist that, she's no longer going to be getting chemotherapy. And breaking bad news is definitely one of the toughest parts of my job. And it's never something I take lightly, because I know I'm about to tell patient bad news that's going to be impacting their life. So that's the next thing I'm thinking of. But I also know I'm not going to be breaking bad news to her till I properly manage her pain, so she's able to comprehend and actually be part of the conversation and spend time with her family. And then I'm also thinking of, back of my head, okay, she's married, she has 3 children. We have to involve her husband in the care. I have to explain to the husband what is going on medically, make sure that I'm providing support to them and the children, making sure the children are okay and they're involved in the mom's care and they're understanding what's going on. And then also back of my head is like, okay, she's very involved in her church and in the community. I want to make sure the chaplain is involved in case she's having any existential distress. But my first thought process is that what I need to do is manage her pain. So then what I will be doing is I would be questioning her. So she's, at this point, either in the emergency room or she's admitted into the hospital. And so then I am consulted. So when it comes to pain management, I would be asking her a very detailed, thorough pain history. So first I would be asking, okay, where is the pain located? In her case, it's the lower extremities, her upper extremities, her hip. And then I would be asking her, okay, what's the quality of the pain? Is it sharp pain? Is it gnawing? Is it stabbing? Is it tingling? Is it burning? Because based on the description of the pain, I will be thinking of different types of pain that exists and what type of pain she has. Because based on the pain she has, whether it's nociceptive, somatic, or neuropathic, I would be giving appropriate medications to manage that pain. And then I'll also be asking her, and is the pain radiating everywhere? Is there anything that makes it worse? Usually patients in her case that have metastatic disease to the bone often say that, when I'm walking, my pain is worse. When I'm sitting, my pain is less. And then I would ask her, is there anything that makes it better? Have you tried any treatments already? You always want to assess that they're not taking any herbal medications that could be causing side effects. So that's the detailed pain history I would be asking. And based on what she would say, describing her pain, or telling me how long it's been going on for, I would figure out whether it is acute pain or chronic pain. So let's say she says, oh, this pain that I have has been going on due to metastatic disease for 6 months. Then I'm thinking, okay, it's a chronic type pain because of her metastatic disease. But then if she's like, this pain started 3 weeks ago, then I would see if I need to obtain additional imaging, like an X-ray, to see if there's a new bone lesion that's coming up. As a doctor, I always want to make sure I'm getting a very thorough medical history to make sure I'm not missing anything and not dismissing her pain. So I would get an X-ray to see, is there a new lesion that has popped up that's causing her pain? Is there a fracture that happened that might be causing her pain? If she's complaining of chest pain, if she has malignancy like cancer, in my head, I'm thinking, you know what? That already puts her at a very high risk of getting a pulmonary embolus. I want to make sure I'm not missing a pulmonary embolus, which is a blood clot in the lung, or I want to make sure I'm not missing, chest pain because of a heart attack. So there are a lot of differential that goes on in my brain, and I want to make sure I'm not missing anything. And then based on her symptoms, based on her saying that, oh, it's been going on for, 3 weeks, I would obtain imaging to see if it's lesion or what it is that's going on. And based on her symptoms, then we would talk about, okay, what type of pain it is. So I want to quickly go over different types of pain. So first is somatic pain. Somatic pain is because of pain receptors in tissue, such as the muscle, skeletals, joints, connective tissue that are activated. Typically stimulation like force, temperature. So if you have a burn, if someone, punched you, and the pain in the somatic type of pain is often described as cramping or gnawing. That's why getting a detailed pain history is really important. The thing with pain is that the way humans feel pain is that there are these receptors in the body that are activated. So there's the mu receptors and there's the delta receptors, there are kappa receptors, and these receptors modulate pain to the brain, telling the brain that I'm in pain. And so a lot of pain medications we use, like opioids, target these receptors, like mu receptors, to kind of, affect as you can see in the picture, these pathways that are activated in pain. So it's actually very cool how the pain works. And so the other type of pain is a nociceptive pain, which is a general term that's described to use physical damage or potential damage to the body. For example, in a sports injury or a dental procedure or arthritis. So her pain is mostly like a nociceptive somatic type of bone pain. So that's the differential that's going through my head. The other example of pains that exists is neuropathic pain. So neuropathic pain is nerve pain that tends to happen when there's injury to the nerve. The most common type of neuropathic pain is diabetic nerve pain. So, patients that have diabetic nerve pain usually say that, oh, my pain in my legs is burning and tingling. And these are key words for neuropathic pain. But this patient, because she has bone pain, I'm thinking more somatic and nociceptive type of pain. So in her case, it's the bone pain, and the treatment that I would use for her is opioids. Now I know opioids always get a bad rep because there's always a potential for abuse, but opioids are very commonly used for palliative care and hospice patients. And a lot of our training in fellowship as a palliative care and hospice doctor is in opioid management. But opioid management for, end of life patients, opioid management for cancer related pain that is so severe that it requires opioids. We always, try to titrate the patients. So when someone comes in, my first guess is not to give opioids. My first guess is to see how severe is the pain. Can we start them with a low, something low like Tylenol? If that doesn't work, do we go up on it? Should I try them on, Percocet? If that doesn't work, then I would try them on morphine and Dilaudid. So there are different type of opioids we used for palliative care and hospice patients, which include morphine, oxycodone, Dilaudid, all all Schedule 2 type drugs. And the choice of opioids I would use for her will depend on her lab function. So what then I would do is go through a detailed history along with checking all her labs and all her medical records. So if this patient has a history of kidney disease, I wouldn't use a certain opioid like morphine, because when someone has morphine is excreted by the kidneys. So then I would think, she has kidney disease, I should use a different type of opioid to manage her pain. So there's a lot that goes on in my head, but it's very important to be, as a doctor, we are very thorough and we're very detail oriented. And so my next step would be to check her kidney function, to check her liver function, to see where the bone metastasis is. And then based on that, decide what type of opioids to use. Some common side effects to opioids are constipation. Constipation is the #1 side effects to opioids. And all opioid providers, every time I write an opioid prescription, my hand also writes a prescription for stool softeners and stimulants, because constipation, if it gets very severe, can actually cause bowel obstruction in patients. So we want to always be very careful when we're giving these patients these high dose opioids that we're also giving them stool softeners. Most patients also experience nausea, vomiting, which is self-limiting. Usually it goes away after 3 to 4 days because your body just needs time to adjust, especially if they're opioid naive. And then, drowsiness can occur. The goal of giving these opioids is, it's always done in a monitored setting. The goal is never to give too much. It's always to give the right amount to where they're able to, perform their daily activities, spend time with their family, and then they're not in pain, because pain can be very debilitating to patients, especially, with cancer. And one of the other things I would be thinking about is that since her pain is so diffuse and it's in her lower extremities and it's in her hands and in her hip, if let's say if she came in with just one pain symptom, if she was saying that I just have hip pain that started 3 weeks ago, and if we did an X-ray and it showed that there's just one lesion due to her metastatic disease, then I would also recommend radiation therapy, because radiation therapy tends to help if it's one or two lesions in the bone compared to multiple lesions. Then the radiation therapy is a little harder. And that's why we tend to lean towards more for opioids if it's multiple lesions. So again, I'm also looking at this patient as a whole. So once I manage her pain symptoms, figure out what type of pain she's having, start her on the opioids, and her pain is a little bit more managed, she's able to participate in other aspects of her life that are contributing to her discomfort. So with this patient, my first goal was to manage her pain. Now we're going to move on to different aspects of her care. The next aspect would be the psychosocial. We're always looking at this patient as a whole. So what's going through my head is that she has 3 children and she's currently married. Then I would be making sure that I'm involving the children and her husband in the care, making sure I'm talking to families and offering support, which is a big part of what we do. We are fierce patient advocates and we're fierce family advocates. A big part of our job is talking to patients' families and explaining to them what is it that's going on, explaining to the husband that, your wife is having pain because of bone lesions she has due to her metastatic disease. And this is why she's admitted to the hospital. We're here for you. We're here to offer you support. If you need anything, if you need us to explain anything, this is what we're here for. So providing support to family and friends is a big part of what we do. Also, kind of getting to know her at a deeper level. She's a biology teacher. That was a big part of who she was. For example, if I was ever admitted into the hospital and no one even got to with a metastatic disease, and people were just focusing on my pain and no one really got to know me at a deeper level, then they would miss the fact that, I am a doctor and, I'm married and I have children and this and that, and it's a big part of who I am. So it's always important, even, throughout your career, always get to know your patients, always get to know them at a deeper level, because it's so important to remember that these are humans you are talking to that have this life of their own, that's a very big part of who they are. So you don't want to be like a robot. That's why, human touch and human care is so different compared to robotic care, right? Because part of being a doctor is being able to connect with these patients at a deeper level, connect with them, really get to know them, get to know what's important to them, what's a big part of their life. So I would definitely involve the social worker in the care to see if there's anything the social worker can do to kind of talk to the patient's children to see if they have any needs that need to be met. So always just look at patients as a whole, in realm of things. So the other part of our care would be, I would also involve the chaplain. So spirituality is a very big part of life. No matter what your religion, even if you don't believe in, even if you don't believe in God or whatever if you believe in like the universe, the way we interact, it's a big part of all human life, no matter what your religious beliefs are. So since she is a Christian, since of the faith to her is a big part of her life, I would make sure that our palliative care chaplain is involved in our care. So the chaplain would come in and do his assessments to make sure that she is happy with where she is spiritually. For some patients, spirituality really helps them, especially end of life, because it's something they rely on heavily. And that could be sometimes a good thing, and that could be sometimes a bad thing if they're having existential distress. Some patients that are end of life or have been diagnosed with a chronic illness that are very spiritual might be thinking, is God punishing me or what's going on? And we want to make sure that we are addressing those needs in a healthy manner and making sure that they're not having unnecessary guilt that could be impacting their life. So again, we're always looking at patient as a whole, which is one of the best things I enjoy about my field. Okay, so the next step is family meetings. So as a palliative care and hospice doctor, especially in the inpatient setting, we have family meetings with families and the patients where majority of the time we are not only providing support to the patient's family and children and the patient themselves, but breaking bad news. So in this case, it would be telling the patients with the oncologist that no longer are we going to be able to offer them chemotherapy. Um, and that could be very, very difficult for families to hear, because you're giving them a life-changing diagnosis, or sometimes giving them a life-changing treatment option. So it's definitely one of the toughest parts about my job, and it's never something, again, I take lightly. But in palliative care, you're trained to have these, complex conversations. And so breaking bad news for this patient would be me going in with the oncologist and telling her and her family that she's no longer a candidate for chemo. So how would I break this bad news? There's a protocol called the SPIKES protocols that we often use in palliative care. And I quickly wanted to go over it because it's something that you could use in all specialties in medicine. Communication as a physician is a big part of what you will be doing. Great physicians are also great communicators that really get to know their patients and are really truly there for them, but are also able to communicate things clearly to them and make them understand that why is it that we're doing what we're doing, constantly updating them on the care they're receiving. And so in order for us to break this bad news, there's certain protocols in place that we learn in fellowship that I want to share with you that would apply to any field of medicine. So the SPIKES protocol stands for setting, patient's assessment, invitations, knowledge, emotions, and strategy. So the first thing I would do is setting up the interview. Okay, so I would make sure that when we're having this family meeting, when I'm about to break this bad news to patient, I'm not just doing it when the TV is on and Jerry Springer is in the background and the patient is just uncomfortable and no family members are around. So usually what we do is we have these meetings in a very quiet setting. So if I'm in the patient's room, I want to make sure that the patient is alert and able to engage in conversation. TV, everything is off. There's chairs set up in patient's room where family members and all of us can sit, and I can properly sit down and talk to the patient and family about what's going on, whether it is patient's room, or sometimes most hospitals have conference rooms where we go in with the patient and the family. So it depends on patient's ambulation status. So that's the setting part. And then the next thing I would do is perception. I would ask them, what is your understanding of what is going on? So I never just want to assume patients know anything, because one of the things I've noticed practicing for a few years now is that there's a lot of there's a lot of gap in communication about what the patient actually understands and what we're telling them. So we might be doing our best and telling them and explaining everything, but they might be understanding something completely different. So it's important to kind of get a perception of what is it that you understand is going on. What have the doctors told you so far? And at that point, the patient would usually say that, I know I have cancer, I have breast cancer that has spread throughout my body. And that's what's going on. And I know I have pain because of the metastasis. And then, with the oncologist and then I would ask the family, how much information do you want to hear? You always want to ask for invitation. You never just want to be like, okay, well, we can't offer you chemotherapy anymore. That's not appropriate, and it's very unprofessional. You want to ask them, is it okay if I share some news with you? And most of the times patients will say yes. sometimes based on cultural differences, patients might say, I don't want to hear any bad news. I don't want to be part of this conversations, but you can talk to my family members. Sometimes we see that with certain Asian cultures where family is a very big part of the patient's life and they don't want to be involved in the decision making or want to hear any bad news. They rather just have their family members get the news, and the eldest son or the patient's partner, they want them to make all the decisions for them, which is completely fine because everyone is entitled to their own way of processing the news and processing their disease. So that's the next step. We usually ask, like, how would you like to receive your information? And then the next part is the knowledge sharing part, which is where, the oncologist and me as a palliative care provider, we tell them that, the cancer has advanced and we are no longer going to be doing any chemotherapy because it's more harmful than doing good. And we've reached the point in that care where chemotherapy is no longer an option. And then after that, we usually we're quiet and we are assessing patients' emotions. We're assessing, are they shocked? Are they, most of the times patients would be crying, or how's the family feeling? And at that point, it's our job as providers to make sure that we're there for them, whether it is they're feeling sad or whether they're feeling shocked, most of the times I'm there holding their hand, being next to them, making sure that they know that I'm here for them no matter what, and that we're not going to be abandoning them. Just because chemotherapy is not an option doesn't mean we won't be treating her symptoms. We are still going to be there for them as the medical team. And then the last step is just strategizing everything, kind of doing a summary that, okay, so this is what happened and this is the information you received. And now we're going to talk about the next steps going forward. So this is kind of like a day in a life of how I hold my family meetings and how a lot of palliative care physicians hold their family meetings. And these are strategies you can use in any field. You always want to be receptive. You always want to communicate things clearly, but at the same time, you want to be there for the patient because you're human and they're human too. And, a lot of us go into medicine to help people and to be there for them. So I always tell all med students and residents to just be kind. You might feel like you're busy and there's a lot going on, but just know this is a human being that you just gave a really bad news to, and that be there for them, be there for them emotionally, and, be just let them know that you're going to be there no matter what. And that's something very important you can do. So the next step is discussing goals of care. Now, what's goals of care conversations? So that's basically, telling the patient, okay, so chemotherapy is no longer an option. So what about, let's say if your heart stops completely on its own, you have metastatic disease, that's going to happen. Would you want CPR? So cardiopulmonary resuscitation is where, we try to restart the heart and we intubate the patient, the airway management, this whole thing that goes in, kind of explaining to them what CPR is and what it entails. And after we explain to them that, this is what the statistics show, patients that usually have metastatic cancer, since there's no underlying disease that we can treat, the percentage of times the cancer works, it's really low. Would you want CPR? Do you not want CPR? When that time comes, do you just want to focus on comfort? If you do want CPR, and if you do want to be intubated, which is like put on the breathing machine, how long would you want it for? Let's say if you're unable to eat, do we just want to do comfort feeds where we're just feeding you? So there's a lot that goes in during these goals of care conversations. And the point of this is to get to know the patient and get to know what's important to them end of life. And based on their goals and wishes, give recommendations. So if someone says that, I really, to me, independence is very important. It's very important for me to be able to, spend time with my family and friends. I don't want to suffer and be on a breathing tube when that time comes. And so based on that, we would give them recommendations like, okay, this is the medical management we will be doing to make sure you're able to be awake and be able to, spend time with your family. We'll make sure that your pain is managed by this opioid or that medication or that treatment. And then this is the goal we'll have. So there's a lot that goes into these goals of care conversations, but the point is always to remember it's about getting to know the patients Our goal is not to convince them or one way or the other. If patient says that they want CPR because that's something they've talked about this with their family and this is what they want, then our job is to support them in that decision and be like, okay, so this is what we will be doing in the meantime, and document these decisions, which is something you will be doing not just as a palliative care and hospice doctor, but any field in medicine, whether it is family medicine or internal medicine. Whatever your field of care is, you will be having these goals of care conversations. And the more you do it, the better you will get at them. But it's important to just kind of get to know the patients first. So then we're going to continue the case. So the patient in this case decided that she wants to, die naturally. She does not want CPR. And her disease continues to progress, and she's admitted again to the hospital. This time she looks very bad. She looks weak. She's unable to talk. She hasn't eaten anything in several days, and it's quite clear that she might have days to live. So she's admitted to the hospital because of severe pain. You manage her pain. And then at night, you are the resident on call, and you are notified that the patient, Mrs. Smith, has died at 2 a.m. and you are called to pronounce her and do a death exam. So this is a common thing that will happen when you are in residency. Patients die. It's a part of life, especially patients that have very severe chronic illness will die. And you will be called to assess this patient and assess what's going on with her. And so most of the times, a lot of times it's at night and you are the resident on call. So you're kind of the one going in alone and assessing the patient, and sometimes with the attending, and sometimes the attending is not around. So you want to be prepared for these situations. So then you go into the patient's room. Prior to going into the patient's room, what you want to do is do a thorough assessment of what the patient was here for, especially if you don't know the patient well. So first you want to check their code status. You want to make sure that in her case, she was DNR, DNI, which means she did not want to be resuscitated. And then you want to make sure that you are, looking at patients' notes before going into the room. You want to make sure that you're kind of fairly, versed on what her medical history is. In her case, metastatic breast cancer, which eventually led her to have all these symptoms and die. So you want to familiar yourself with that. You also want to, make sure that who's involved in her care, her family, her husband, what's going on. So you kind of just want to have a little bit of summary before going into the room. You just don't want to walk into the patient's room after the nurse tell you she has died without having any idea of who she is or what's going on. And then you go into the room, you look at the patient's tags to make sure that it's the right patient that you have reviewed labs and things for. And then you identify the patient. You call their name. You want to make sure that they are dead, and there is some physical exams that you do that you will be trained in medical school and residency. A lot of times, you're checking the pupillary reflex to see if there's any reflex or not. You're checking their radial pulse. You are checking their carotid pulse. You are checking their heart. You are auscultating them to make sure there are no heartbeats. Sometimes at places they, obtain like a rhythm to make sure that it's flatlined and there's no electrical activity in the heart. And you're assessing their respiratory status. You check their, vitals to make sure that they're matching what you're seeing. And then, before performing the physical exam, especially now during COVID, you want to make sure you have the proper PPE, you're washing your hands, and going in, protecting yourself. And then sometimes in ICU settings, if they're brain dead, then you do these apnea tests. So there's a lot that goes into some certain types of physical exams that are performed. And now I kind of want to touch base on, dealing with a patient's death. So let's say if you knew this patient for a very long time and you took care of her, and now that she has died, what is it that, you should kind of be looking out for? So death is a normal part of life, but doesn't make it any easier. Seeing a patient die is something all of us in the medical field, no matter what you are, either medical student, nurse, physician, will go through. And it's something all medical providers will experience, but it's good. It's important to have healthy coping strategies through these situations, and to know that this is not easy. It's never going to be easy to see a patient die. You're seeing another human lose their life. It's not easy. And to understand that it's not easy, and not really be numb to it, because that's not healthy. You want to be able to process these things in a healthy manner. So the first thing I always suggest is to express your emotions. If you are very close to the patient and you've seen them for months or years, or sometimes, decades, you want to be able to let yourself feel the loss. You just lost a patient that you got really close to. And that's a big deal. And you should let yourself feel these emotions. If you're feeling angry, if you're feeling sad, let yourself feel it, but it's also really important to talk to people, openly talk about what you're feeling with your colleagues, your co-residents, or people you're in med school with, or people you're going to get very close to. So if you feel like this was something that really hit hard to you, then talk to them. I was taking care of this patient for a very long time. I'm really sad. It was just so sad. She had children and she was married, and to see that really impacted me. Be able to express yourself more openly during these situations. Take time to reflect. Everyone deals with patient's loss in their own way. Take some time to reflect on what is it that you just saw. That's not normal to see that, but at the same time, it's a part of life. And one of the book recommendations I always give is Uphill Go On is Being Mortal. It's important to, read these type of medical books to kind of learn about the culture of medicine and how it is that people deal with death and dying, and something all of us will experience at one point in our lives too. So take some time to reflect. Don't ever feel like a patient's death, like this patient that died of metastatic cancer, is any way, shape, or form failure on your end. Dispel any feelings of failure. This has nothing to do with you. You can't control if someone gets metastatic cancer or any other chronic illness. I'm not talking about medical related things that might happen, but you don't control someone else's medical issues, and these things happen. Patients die, and don't ever let yourself feel like, oh, you could have done something different, or feel something different. Just know that this is a part of life, and it's okay to feel the way you're feeling. If it gets harder, obviously, if you feel like you're starting to lose sleep and you're not eating well, and these signs that you start noticing in yourself that, okay, I'm not processing this properly, then speak to a licensed therapist. It's really important to acknowledge some of the feelings you're feeling. And if you feel like they're really impacting your life, then it's very, very important to speak to someone, and ask for help. Don't ever be afraid to ask for help. Okay, so that was just like an overview of palliative care and hospice and all I do. I know this was a little heavy topic, and I hope you guys benefited from it. Next, I just want to kind of talk about advice for medical school in general. But before I dive into that, I just want to thank you again for taking time to listen to all this. I know this is not easy. It's not easy to hear about, these chronic serious patients. It's hard. These are hard topics. But the fact that you have took time to listen to this also says a lot about you, that you want to learn more about medicine. You want to learn about patient care. You want to learn about all of it, not just like the nice and pretty in medicine, but also like the true side of medicines you will see. So, this wasn't easy, but I'm proud of you guys for sitting through this. So quick advice for medical school. One thing I always tell people is to, always get a mentor, shadow doctors. When I was in college, I didn't have parents that were doctors. So, but I had like no help or no backup. So a lot of it was me kind of cold calling doctors' offices to be like, hey, can I shadow you? In college, I joined a lot of medical organizations that would sometimes help us get these mentors and shadow doctors. A lot of, I joined medical associations that hosted doctors so I could talk to more doctors. A lot of it is kind of like hustling if you don't have help. So that's something I did. I called a lot of doctors to see if I could shadow them, because the reality is, medicine can be all this and that, but till you actually shadow a doctor, till you actually do things in medicine, that's when you truly realize if you really like it or not. Because you never know if you like something till you actually do it. The next thing I always suggest is to volunteer. All of us go into medical school to help people. So you want to show the medical school applicant committee that you like to help people. I know it sounds very cliche, but it's important, you know. Also, study early, apply early. Make sure you're applying to. I applied to medical schools right when the application opened up. I wanted to make sure that I was the first applicant they saw. I was made sure that all my letters of recommendations and essays and everything was in, because you can start uploading things, but you might not be able to submit when things open up. But the earlier you are, the better it is. So make sure you're applying very early. You're studying earlier for exams that you have to take, because these are very tough exams that you take to get into medical school. So it's not something you can just cram in 24 hours. You have to study months in advance. It's always like a marathon, and then always get involved in extracurricular activities like web shadowers and all these other organizations that help other students get involved and interested in medicine. And then lastly, I would say be humble and be kind. Just being in medicine, you will be seeing so much and doing so much, and it's so important to continue to just be kind and be humble and be kind to people, because that's what we do as doctors. You want to be a good physician, and a good physician is always someone that is kind to other humans. And then lastly, I would say that it's not, medicine is not a easy road. There are no shortcuts. It requires a lot of hard work and discipline. But I would say believe in yourself. It's like the best advice I ever got. You have to believe in yourself. No one else is going to believe in it for you. You have to believe in your own abilities. You have to tell yourself, it's the conversation you have with yourself. So you always have to tell yourself, like, you know what, I can do this. This is something I want. I cannot tell you the amount of times in medical school, and the amount of times in college I was told, like, oh, medicine is too hard, try something else, or maybe your scores are not high enough. But I always just kept pushing, because I believed in myself. And even if my score wasn't the highest, even though, no matter how much extracurricular activities I did, even if my grades weren't the highest, I'm always a believer in just going for it and trying. And if you just go for it and try, you never know what might happen, So thank you for this. And I'm going to answer some of the questions. Okay, there's chat. The first question is, the chaplain, are they affiliated with specific religion? That is a great question. They are not affiliated with specific religion. They are multi-religion. I don't know if that's a word, but they're basically, most of them, some of them are as Christians, some of them have a Muslim faith, some of them have a Jewish faith. So the chaplains that are available have a certain faith they might be a part of, but they are universal. They see patients that are from all types of faith. But most hospitals, you can request a specific chaplain that is from your religion. So, for example, if you're a Muslim, then you can request like a Muslim spiritual provider. If you're Christian, you can request a Christian chaplain. If you are Jewish, you can request a Jewish religious provider. So every hospital is different, but most of them are universal. How does HIPAA regulation play a role in keeping families informed and involved in patients' care? Does it make it harder or restrict when you can inform them of? How do you take care of your own mental well-being when dealing with heavy topics like this? That's a great question. So when it comes to HIPAA, the first thing we always do is ask the patient, can I disclose this information to your loved one? Can I disclose this information to your husband? Can I disclose this information to your children? Can I disclose this information to your sister? We never disclose any medical information with family unless we have the patient's permission, because that's the first thing you have to do in any field. So no information is ever shared without the patient's permission. And how do I take care of my mental well-being? Yes, so that's one of the most important parts. Palliative care and hospice is not for everyone. I also practice as an internal medicine hospitalist, which is a big part of what I do. And I would say for my mental well-being, I am blessed with an incredible family and friends that are always supportive. I always check in with myself, and it's something you should always do, even just being a medical student or being a resident. Important check in with yourself to see, like, how do I feel mentally? Is this getting too much, or is it getting, is it bothering me? What's bothering me? So I've always been very good at self-reflecting. I also meditate. I have a very healthy, I try to exercise. I have a very healthy lifestyle, and all that helps. How are opioid crisis change the way you use opioids in pain management? So the question is great. It says, how does opioid crisis change the way you used opioid management? Does the cost affect patient decision making in end of life treatment? So opioids are actually pretty cheap depending on the type of opioids you use. And yes, the opioid crisis has produced a lot of misinformation on opioids, because these opioids that I'm using are not for um, general population. This is for end of life patients, which is a whole different ball game. This is not someone that's like has back pain for a while. This is a patient that has active malignancy and cancer that has metastasized, is causing them severe pain. And that's kind of what opioids were created for. It's this patient population, but it's also created a lot of scare and misinformation for patients, because they're always scared, like, okay, is this gonna, am I going to get addicted, or is it going to be drowsy? And before we prescribe opioids, we always assess patients like addiction risk tools. We always assess, do they have a history of substance abuse in the past? Do they have a history of abuse in general? So it's not like, someone comes in and we just prescribe opioids right away. There's a whole different, assessment that goes on to make sure that that we can safely prescribe to this patient. That was a great question. How do you balance what the patient family want, versus what is best for them? For example, what if patient wants to work with increasing pain and decreasing life expectancy? That's a great question, because a lot of what we do is it's constant talking to patients, and the conversation changes every time. So what usually ends up happening is that, we see these patients in clinic. So let's say we see the patient in clinic, the patient's like, I'm having more pain and I'm more sleepier, but I still want to continue to work. Then we ask, what type of work is it that they're doing? Is it safe for them to go back to work? And we involve their family in the conversation. We really talk to them like, hey, this is what's going on. This is what the labs are showing. I don't think you'll be able to work longer. But in the end, my goal is always to be able to maintain patients' autonomy. That's why we're providing them with opioids or these other type of symptom management, whether it is physical therapy. If someone says, my bone pain is so worse, but I want to be able to work, then I can get the physical therapist involved to see if are there exercises, modifications we can do. Maybe we can give them crutches so that they could still go to work, because that's a big part of who they are, and we want to continue to maintain patients' autonomy. Next is, how do you handle cases where the patient says they would rather have their spouse and children not know what is happening? And that actually happens several times. So we always have to respect patients' wishes. If a patient tells me that they don't want their family to know, my job is not just to be like, all right, well, I guess I won't tell them. My job is get to know, why is it that they don't want family members to know? Is there something going on? Is there, something I'm missing? Is there abuse going on in the family? Or is it that you don't feel close to them? Or is it that you're afraid that the children might, react a certain way? And that's when the interdisciplinary team comes in. That's why, it's not just me, it's the social worker. So maybe this patient would benefit from a social worker visit where the social worker can address certain needs so the family can get involved. And that's why it's just so many facets to this. And it's not just like, you don't just say, if they say no, then we respect their wishes, but we also get to know, why is it that you're feeling these things? There's always a reason for why people say and do what they do. Maybe we need to get a child therapist involved so there's easier way to facilitate the conversation about her illness and her metastatic disease, so then the kids can know what's really going on. So, it's a lot of it is also coordinating care with the psychologist, the chaplain, the social worker, the grief therapist, to see what's best for the patient. Um, how do you protect yourself emotionally from being exposed to death all the time? This is a question I often ask myself, especially during this pandemic, working at a pop-up hospital in New York City, where I saw so many patients die. Um, and it's never easy. Death is not something you just get used to, but you learn healthy coping mechanisms. I've learned to have a healthy way to process these emotions. I always check in with myself. I meditate. When I start feeling like I'm getting very overwhelmed, I take time off. I take time off to focus on myself. So a lot of it is, being able to kind of deal with these situations in a healthy manner. And it's not easy. It's not for everyone, but for me, it's very rewarding in general to be able to help these patients, knowing that my job, we will all die and it's a part of life. But if I can make sure that this patient is pain-free and symptom-free as possible and comfortable as possible, then that's very rewarding for me. What is the process of becoming a locum doctor? Okay, so the process of becoming a locum doctor is that there's no actual process. What happens when you're done with residency and you're ready to practice as a attending physician on your own, what you could do is you can reach out to these locum companies. So there are a bunch of companies that hire locum doctors. And what they do is that they interview you, and they see if you're a good fit for like the hospitals they have there, where there's a shortage of doctors. And then you talk to the hospital where you're going to be assigned to for like a week out of the month, and you get to know them, see if you're a good fit. And so that's how you can kind of incorporate being a locum doctor. There's a lot of resources for that online, and I'm definitely going to share some more resources on my IG page in the coming months. Let's see, what else? How do you deal with patients who believe in homeopathy and herbal care more than pharmaceuticals for care? So with that, a lot of it is just kind of talking to patients and getting to know what their thought process is regarding, herbal care. In the end, we do what the patient wants. Patient has the last say, but we try our best to kind of help them understand why, so that we're using certain medications and why this might not be helpful for you. But in the end, it is the patient's choice. But it's our job as providers to be able to kind of understand what they believe this herbal medication will do and how it's going to help them and how medicine can actually help. So it's 5:08. It's almost time. It's time for me to end this session. But thank you so much again. I am active on my Instagram page. That's like one way you can reach me. If you have any more questions, feel free to reach out to me. I do my best to answer any questions I receive through IG. My IG is Dr. Lalani, so Dr.Lalani. And I'm constantly posting a lot of internal medicine topics on there and palliative care content on there. So to be able to help, further understanding. So you can reach me there. You can also email me. I'll share my email with Web Shadowers. So thank you again so much. I really appreciate you guys listening, and I hope this session was helpful. Thank you.
Thank you so much, Dr. Laulani. This was a wonderful presentation.
Thank you.
It's a tough topic, but everyone learned so much. Thank you so much again for taking the time to do this. For everyone watching, the Google form has been posted in the YouTube chat box, and that will be open for another 30 minutes from now. So I'll close it at around 5:40 Eastern. And just a quick announcement, as you guys probably know, this weekend we're doing our October roundups. So from Friday, October 30th at 11:59 p.m. Eastern Time to Sunday, November 1st at 11:59 p.m. Eastern, you guys will be able to go back and fill out all of the Google Forms from the October sessions. This is completely optional. It just gives you a chance to get credit for the sessions you may not have been able to watch live. There's going to be a document posted on our website with every single link. and the forms will be open for responses at the designated time. The forms are all the same as the live ones, except you'll have to write a 10-sentence summary to get credit. If you have any more questions or want to know any more information about this, we have an Instagram post on our Web Shadowers Instagram it's orange and spooky themed, if that helps you find it, with more information. So thank you so much, everyone, and thank you again, Dr.
Have a
Lalani.
great day.